This video will be broken in two halves, simply because it's a little long. It was on heel pain. When I was talking about heel pain, I was talking about the pad area, the heel pad area. Not looking at the Achilles tendon or the bursa at the back there, just the heel pad area. However, I found that I really couldn't do this without bringing in plantar fasciopathy. So we've gone a little way into the midfoot because plantar fascia pain is actually distal and medial to the heel pad area. So bearing that in mind, that the rest of this will be about the heel pad. So we'll start with plantar fasciopathy. Plantar fasciitis is a term that's used almost universally, and it shouldn't be. It's a misnomer, and it's a generalization that doesn't stand up either to semantics or to pathology. Plantar fasciitis is an inflammatory condition, and we very rarely see that in our clinics. What we see mostly is plantar fasciosis. So let's distinguish between the two, because if we don't, we're going to mess up the diagnosis and we're definitely going to mess up the treatments. So we'll start with plantar fasciitis. This is an inflamed fascia, particularly at the attachment to the calcaneus. The onset is sudden with severe stress. So we could be looking at a torn plantar fascia, or it could simply be severe overuse. Or it can come on gradually, and this is often as part of another medical condition, such as systemic arthropathy, ankylosing spondylitis, and so on. So this can be a larger condition, which is one reason why you have to understand the difference between plantar fasciitis and plantar fasciosis, or it can be a traumatic experience. The pain that is felt is generally in the same place as plantar fasciosis, that is immediately distal to the heel pad and medial. But it is traumatic. You can tear the plantar fascia in the body of the fascia, so further into the midfoot. With this, you'll get increasing pain with each step. This is not what you see. This is not the patient who says, this is much, much worse after long periods of weight bearing, particularly in the morning. And then when I walk on it, it'll get better. If I keep walking on it, it'll often get bad again. But if I walk for a few steps, it will feel better as I do that. This is not that anymore. This gets worse and worse and worse. And if you think about it, how can an inflamed tissue actually get better when you continue stressing it? It's just ridiculous. With plantar fasciitis, it's exquisitely tender. If you try and palpate for plantar fasciosis, there's effort involved. You have to dig your thumb in deep into the area and flap around trying to find it. There isn't any of that. You push in a little bit and they're basically yelling at you before you get too deep. There's irritability with this as well. So if they walk too far on this, it will hurt while they're doing it, but when they stop, it will ache for a period afterwards. So this is the typical irritability you see with with an inflammatory condition. The windlass test will probably be positive when you do it on a plantar fasciitis. And if you're not sure what the windlass test is, it's basically tightening up the plantar fascia from both ends and stressing it out. So you basically put the foot flat on the floor, the patient squats over it, brings a knee over the dorsum of the foot, and then you extend the big toe, and you're looking for a reproduction of their pain. That's a windlass test. It's easier to do it by already dorsiflexing the toe and then getting a squat over it, but it's a little less specific, and we can go into that another time. To make sure this isn't a fracture or a bone pathology, the squeeze test will be negative when you have this condition. And the squeeze test, if you're not sure, is you actually squeeze the sides of the calcaneus, either between finger and thumb, or you can squeeze it between the thenar eminences, which spreads the pressure of it so you don't get the tenderness from the finger and thumb, but you're reproducing their pain when you do that. If that doesn't work, you can also squeeze it longitudinally through the talus and the heel and squeeze them together, and that'll produce a longitudinal stress. Plantar fasciitis is what you're used to seeing. This is a patient who says exactly that. Worse after a prolonged period of weight bearing. It hurts when I walk on it, but then it eases up after a number of steps. This is degeneration in working. It just gets a bit better when you put more stress on it. If you put too much stress on it, it'll keep on hurting. But it's not particularly irritable. When you stop the activity, the pain will stop as well. You need very deep pressure to get the tenderness. The windless test in this case is almost certainly going to be negative. The only way you may be able to get it to be positive is to have them sit for a prolonged period of time, and then do the test. It might just be positive then, otherwise this is almost always negative with fasciitis. And again, the squeeze test should be negative. Okay, just for your edification, this is an MRI of plantar fasciitis. There's thickening of the plantar fascia, and it's a degenerative condition. If this is actually inflamed, then you're going to get a heightened signal from the MRI, but this one is thickening. So now the fat pad. There are different diseases that affect this. The fat pad can get atrophied, and one of the commonest causes, I think, of fat pad atrophy, in my experience anyway, is a patient with plantar fasciopathy or fasciitis or fasciosis. They change the way they bear weight through the heels to get the weight off of the fascia to stop it stressing, and then you start wearing away at the fat pad. There are conditions that do this. They seem to be part of a generalized disease process, and you can also get it from prolonged periods in bed. People with deep comas often produce this as well. There's this pain with every step that you put through it. When you palpate through the fat pad, you can generally palpate the underlying calcaneum, and that is tender. That's bone tenderness. Squeeze test again is negative. Now, you may be able to do this with atrophy. If you squeeze the fat pad together, now we're not squeezing the calcaneum, now we're squeezing the sides of the fat pad, squeezing together, and then palpating into the fat pad. And often you can get enough fat pad together that you lose the ability to palpate the calcaneum, and it becomes much less tender. This is more usual, though, when the fat pad is rather than atrophied, has been spread. It can dislocate and it can spread. And it's usually a heel thump that does this. Anyway, the fat pad spreads out, and again, you can palpate through there, and you can recover it when you squeeze the fat pad together. It's also gives an indication of treatment in these people, because you can sometimes tape the fat pad there and they can walk on it. And then you can basically look at any sort of orthotic that can do that for you. So that's atrophy. Fat pad inflammation, trauma can do this. I'm pretty sure inflammatory conditions can do this as well. So you get, again, much more pain at the heel pad than you would do with an atrophy. Again, there's pain with each step, and now there's irritability as well. So this will get worse the more you do, and you'll ache for longer periods, the more irritable it is. Calcaneum now is not palpable, but you can do fairly superficial palpation and reproduce that tenderness. And again, squeezing the heel pain transversely may increase their pain. So there's an image of fat pad atrophy right where the yellow arrow is, and if you're treating plantar fasciopathy, it's well worthwhile making sure that the tenderness is still where it was when you started. That is under the heel. Often you'll find that you treat the plantar fascia and the patient isn't getting better. And it's because the plantar fascia may be getting better, but the atrophy of the heel pad isn't. And it will change, the history will change a little bit, but it can be much more of an issue. So treating the fat pad, an atrophied fat pad, I've been trying to use shockwave on it. It may help. I'm really not sure, but it may help over a long enough period. But it's much more difficult to read this. Now you're really into orthotics. Okay, fractures, macrotraumatic fractures. If these are bad enough, they're never going to come into your clinic. as an undiagnosed case. This is extremely disabling. It's a drop down onto your heel from not very high sometimes, just a couple of feet can do it. You come right down on your heel, and often you'll fracture a bone in the lumbar spine when you do this. If this thing is really broken up, they're not going to come and see you. But you can have milder fractures that may well end up coming to see you. Don't forget now, you're looking for a sudden onset of the severest pain patients had within an hour or so of the incident. That in itself tells you there's a tissue disruption. Generally speaking, with a healthy bone fracture, you'll see bruising on the lateral medial side of the calcaneus. Stress and pathological fractures, a little different. If we're looking at stress fractures, you're looking at seriously excessive amounts of exercise, much more than the patient's used to. One of the big places for this is actually in the armies. And what they found here was that these fractures occurred within about a month of them starting training. And you've got so many different things happening, changes in shoe width, changes in matrix, the amount of time spent on your feet, all of this comes in and fractures the calcaneus. If there is no stress, no excessive stress or brand new stress, then you're probably looking at pathological fracture. Both of these can come from minor trauma. You can have the bone has been basically taken to breaking point with the stresses or the pathology. You come down a little heavy and bang, you've got this sudden onset of severe pain where there may not have been any before. So bear that in mind. Stress fractures, generally speaking, there's a gradual increase in pain and a gradually increasing amount of disability like there is everywhere else. Except when you have a fracture that is stressing out and then you finish it off with a fairly minor trauma. The squeeze test now will be positive both in the open fracture, the macrotraumatic fracture, and in the stress or pathological fracture. But with stress and pathological fracture, there may or may not be bruising. Okay, so there you go. There's pictures of stress fractures. The MRI on the left is the better study. X-rays probably won't show a stress fracture in its early stages and sometimes never show the stress fracture, even when it's at its peak. MRIs are the most sensitive and specific test for a stress fracture. And you can see these two quite happily. Okay, and there's some images of a calcaneal cyst. On the left, there's the MRI. On the right, there's the X-ray, and they both show up quite nicely. And again, these are going to be vulnerable to the stress test. Having said that, it's probably not a good idea if you have a macrotraumatic fracture to do the stress test. Save that for when it looks like it being a stress fracture or a pathological fracture. The lower image is showing the calcaneal squeeze test. I have no idea why they're doing it from that position. It's generally you just stand straight onto the foot and squeeze it between your arms. But that's all it is. You're squeezing it, mostly transversely, but as I said, also longitudinally can be done as well.